this webinar. Thank you very much for joining us. So this is the Usher Institute at the University of Edinburgh's webinar series on the COVID pandemic. So my name is Linda Bauld. I'm a professor of public health here in the Usher Institute, and I'm chairing on behalf of Aziz Sheikh, who's our director here at the Usher. The remit of the webinars is to try and bring experts in from around the world, a variety of different countries, to provide actionable insights in terms of how we address the pandemic and also how we think about some of the consequences of the measures that have been introduced. We know from the World Health Organization that we now have over 1.5 million cases globally, and many countries are finding it incredibly difficult to deal with the pandemic, and some are doing better than others. So it will be really interesting to hear today about Canada's experience. So last week we were very fortunate to hear from Professor Tingbo Liang, who was talking about prevention and treatment of COVID-19. He was the lead author of the handbook that came from China some weeks ago. So we had his webinar then. I'll introduce our speaker for today in a moment, but I just wanted to say a few words of thanks to Aziz Sheikh for establishing the webinar series, to Susan Buckingham and the communication teams from Usher who supported me to put these webinars together. So we are going to allow questions at the end. And just to remind people, please use the question and answer box that you see in the Zoom tools. There's also a chat box, which is for a different purpose. So please use the Q&A panel, and there will be time to have a number of questions at the end. So I'm delighted to be able to introduce my colleague, Professor Stephen Hoffman. He's the Scientific Director of the Institutes of Population and Public Health at the Canadian Institutes of Health Research. He's also the Director of the Global Strategy Lab at the University of York University in Ontario. And he's also the Professor of Global Health, Law and Political Sciences at York, amongst many other affiliations and titles. So thank you very much for joining us, Stephen, and we're looking forward to hearing about Canada's experience to date.
Great. So first, a big thank you to you, Professor Bauld, for the invitation, as well as the Usher Institutes. I think it's really important that we're able to have this kind of webinar at a time of physical distancing. It's more important than ever that we're able to connect like this, to make sure that we can share experiences from across countries and make sure that we can address this outbreak, this pandemic, as best as we can. So by way of background, so I'm going to present about the Canadian response to COVID-19. Right at the beginning, I wanted to flag that I don't perceive that any response is a perfect response. And indeed, no one in Canada would say that the Canadian response has been perfect. But one thing that is clear from our perspective is that I think that we've done a relatively good job in it, in that we were quite lucky at the beginning that we had cases slightly later. The earlier cases that we had were quickly contained. And of course, at this point, there is now community transmission in Canada, and we've seen over time an increasing number of measures having to be taken, but that overall, the response has been informed by evidence, and it's one that I would say is has been relatively measured. And so now, and overall then, when I would say if I got to choose what country to live in during an outbreak, I would say that Canada would be in the handful of countries that I would want to be in. And so I feel very lucky. Noting, of course, that we're early days and lots can still happen, but I wanted to lay out that context. And so to convey that, what I'll try to do is 4 things. I'm going to first give a little bit of background about Canada for those who aren't familiar with the way we organize health in our country. The second is I'm going to walk through a timeline conveying how this outbreak came to Canada and sort of the timeline of the response from January until today. From there, what I'll do is I'm going to analyze sort of and group that kind of response into different ways, offering some reflections. And finally, I'll share some final notes about some key lessons that I think we've learned in a global context. So I'll do that, and I hope everyone can see my slides. So before I do that, let me just convey, so I'm, as Linda mentioned, I'm a scientific director at the Canadian Institutes of Health Research. We are the Canadian government's health research funding agency. And so I'm specifically responsible for leading the Institute of Population and Public Health, which means that I'm responsible for funding and supporting population public health research across the country. In the context of an outbreak like this, you can imagine the Institute of Population Public Health would be very busy, and indeed it's been quite an extraordinary time over these last 14 weeks since this outbreak was first announced to the world. And we've been working very closely with our counterparts at the Institute of Infection and Immunity to co-lead the Government of Canada's research response to this outbreak. So a bit about Canada. So Canada 101, I'll try to capture in one slide or two. The first is that Canada is a federal system, has a federal system of government. By that, what I mean is that we have multiple layers of government. We have a national government that's responsible, yes, for providing specific health services, such as in the context of our military, prison population, as well as a special responsibility for health when it comes to working with Indigenous communities. We then have the provinces, such as Ontario, where I live, which is then responsible for healthcare in our country, according to our constitution, more broadly. And then public health is this one that's in the middle, where there's actually shared responsibility. So when it comes to public health, we see that in Canada, there is a Public Health Agency of Canada, but we also have provincial authorities that are responsible for public health. And indeed, I would say in Canada, some of the most significant public health really happens at the local level, which I think makes sense given public health ultimately is really a local matter in need of local and precision efforts that are adjusted for a local context and in light of local realities. So we have that in Canada. We have public health at multiple levels. The only other slide I'll show about the Canadian context is this one. It's a bit of a chaotic slide, but it's one that highlights the way that public health is coordinated in Canada. And the reason I bring this forward is because in Canada in 2003, we experienced some rather harsh lessons from SARS in the sense that Toronto was the site of a secondary outbreak. And as a result, we had it quite bad. And some of the things that we recognized during SARS was that our public health system was not very well coordinated, especially between levels of government, but also between Canada and the rest of the world. And so as a result, after SARS, quite a few things changed in the Canadian context, which I think are very important changes, and very lucky that those changes happened because they do better prepare us for the current COVID-19 outbreak. Some of those changes, for example, is the creation of the Public Health Agency of Canada, that national authority as a separate federal government entity, as well as the creation of several tables for coordination. So there is a Public Health Network Council that brings together deputy ministers and chief medical officers. There is a separate council of chief medical officers that allows our federal government to coordinate and get on the same page as provinces and to have joint responses. And then there's a series of programmatic works that feed in, one of which is on communicable diseases, of which a big focus has been on pandemic preparedness, but it's also other issues. So this type of coordination isn't just about pandemics, it's also been about the range of health issues that we would expect public health authorities to address. But in this case, this architecture was in place and is being used every day in the current response. In terms of COVID-19 in Canada, let me just start off with a bit of our current situation, or our situation as of yesterday. So if you look at our overall population, there's 37.6 million Canadians in our country. Our first case of COVID-19 was detected on January 25th, 2020. Fortunately, the first few cases that were identified were quickly contained, such that there wasn't further spread from those initial cases, such that, and that's really what allowed us to have the start of our outbreak much later than other countries, which allowed us to learn from the experience of other countries. Although it was also probably the good public health system that we have that enabled us to very quickly detect and contain those initial cases. But of course, like every country that's seen COVID-19, it's just a matter of time before there starts to be community transmission. So as of yesterday in Canada, there were 18,000 cases, 447, and unfortunately 401 deaths in our country, which certainly as those numbers have increased, we've also seen the response increase. In Canada, we don't have, it's not equally spread across the country, just like our population isn't equally spread across the country. And so this is a figure, again, current as of yesterday, highlighting where cases are in the country. And so what we see is that there basically is a proportionate spread of cases based on population, with the one exception that our province of Quebec, which accounts for about 1/3 of the Canadian population, has about 50% of cases. So it has hit Quebec earlier and harder as compared to other parts of the country at this point. So let's do a chronology of where this started and how the Canadian response unfolded from there. January is easy, so January fits on one slide. As everyone here might remember, January 7th was when China confirmed COVID-19. It was before then, on December 31st, that China had reported some initial cluster of viral pneumonia cases to the World Health Organization. And it was really more publicly announced and acknowledged on January 7th. 8 days later, the Canadian Public Health Agency activated its Emergency Operations Center, which means that it was then starting to get ready in case something did happen. Although at that point, everyone hoped it wasn't going to be anything significant. And it was a week later, on January 22nd, that at the Canadian border, there were already additional screening requirements. Basically, what that meant was whenever someone arrived at a Canadian airport, they were asked, have they been to the province of Hubei in China, and do they have symptoms? That was, and usually that's filled out on an electronic screen where people punch in yes or no. And if it was a yes, it would prompt additional questions from border officials. That happened a week after the Emergency Operations Center got opened, but it happened also importantly even before Canada had its first case. From there, January 25th was when Canada had the first case, and it was 5 days later that WHO declared COVID-19 to be a public health emergency of international concern. Once that happened, moving to February, the first thing that actually Canada's response was actually a research response. And so you'll hear me talk a little bit more about this because I think it's quite significant, but also because I was involved in this. On February 5th, when Canada had only a few cases, the Canadian Institutes of Health Research, at which I work, actually already pre-announced a rapid research response funding opportunity. Basically, it was an open call to Canadian-based researchers to submit their best ideas in order to address this increasingly concerning outbreak that at that point we were mostly seeing in China, but had been starting to spread to other countries, Iran, for example, and then also we'd had our first case in Canada. It was a few days later that Canada expanded its border screening measures. And then on February 10th, we launched a $26 million rapid response funding opportunity. And so that's important because basically there were 7 cases in the country, and we announced $26 million worth of research investment, which is significant because I guess on a per person basis, it's on one hand not a proportional response, except that based on what we were seeing around the world, we knew that this was going to get worse. And so we needed to act quickly and act boldly. And I think we did. So then on February 20th, 10 days after that, was the first time that Canada saw a case that was unrelated to travel from China, the place where this originated. And then a week later, we actually were able to award those grants that had been launched formally on February 10th. And I'll speak to more about that towards the end of my presentation when I walk through that. March was much busier. So March was, I think, the time when it seemed like every day there was a new announcement of a new concerning facts as well as an even bolder response from government in Canada, but also around the world. And so on March 9th was unfortunately the day when Canada confirmed its first death from COVID-19. It was 2 days later that WHO declared this a pandemic. And 2 days after that was the day when things really came down in a very strong way, and when Canada decided that we needed a very robust response and it had to be early. I remember March 13 very well. It was a Friday, and I just remember that was the day that Canada advised Canadians to avoid all non-essential travel outside of the country. And indeed, when our Prime Minister made it very clear that he asked all Canadians to come home to Canada as they can. And he added at the time, as commercial travel is still working. And I remember at the time thinking, as commercial travel is still working, I'd never sort of imagined that there would be the kind of travel constraints that we've been seeing. But of course, our Prime Minister knew things that others did not, and knew that what was happening and might be in play. And indeed, that advice was followed by 1 million Canadians who, over the next week, did return to Canada in light of that advice and the evolving situation around the world. That was the day also that Ontario, the largest province in Canada, the province I live in, announced school closures. And it was the day that Toronto, which is the city I live in, actually asked returning travelers to self-quarantine for 14 days. So that actually affected me. Just 6 days earlier, I had returned from the UK from work there. And so suddenly I found myself in quarantine for another 8 days for the rest of the 14 days. So that was quite a day. Moving beyond that, though, on March 16th, that's when I think the sort of social distancing and physical distancing, that mantra really got rolled out right across our country. And indeed, Canada asked, now expanding what Toronto was asking, and it was now for the whole country, the government asked all travelers returning from abroad to self-quarantine for 14 days. And this really was an effort to try to not eliminate the spread. I mean, at this point, there were already, as you see on the bottom of the slide, there were already over 200 cases. Within Canada, but it was an idea to reduce the number of new cases that might be caused from related to travel. And then it was a couple days later that Canada took two very bold moves. The first was to announce a huge financial package, $82 billion in economic aid. $82 billion Canadian would be about 70 billion American dollars. So huge from a Canadian perspective. And also at the same time, Canada implemented a travel ban, essentially preventing those who are not Canadian citizens, not permanent residents, and not family members of either, or not essential workers, to come to Canada, with the exception of the United States. That with the United States happened a few days later on March 20th, where the border closed to non-essential travelers. And a few days later, we started to see actually even further closures. So closure of non-essential businesses, offering some additional supports to those businesses and workers. More recently, closure of parks and recreational centers. As well, one of the things that's, I think, is quite important, on March 25th, Canada used its Quarantine Act, which is an act of parliament that allows it to order people into quarantine under threat of rather significant penalties and even jail time. So now anyone who does return to Canada from abroad, or just comes to Canada from abroad, is subject to a 14-day quarantine order. And if someone violates that, the penalties could be in the hundreds of thousands of dollars and quite significant jail time. So it's a serious act of parliament, and it's being used for a serious time. April, I guess, has just started. And so I left this slide purposefully blank to highlight who knows what's coming next. But one of the important things that happened on April 1st which was definitely not an April Fool's joke, was around announcement of the Canada Emergency Wage Subsidy. This essentially is a support to businesses that if a business has reduction in their income by at least 30% as a response to COVID-19, then the government is willing to subsidize employees' salaries by 75% in order to enable businesses to retain their workers. It's an extraordinary measure that will cost the Canadian government additional $72 billion. And it's really meant to help Canadians keep their jobs. One thing that's important is that around that time, it was announced that 1 million Canadians had lost their jobs. And indeed, just on Monday of this week, it was announced that 3 million Canadians have applied for an emergency income supplement in light of COVID-19. So this is a significant portion of the Canadian workforce that's been affected, and the government in turn is responding in a significant way. And then actually yesterday it was announced, not on the slide, that any company that had hired a student through the Canadian Student Work Program, the government's actually going to subsidize those salaries by 100% if companies retain those students, which I think, as someone who's in the education system, I think that's really important. So that was the chronology, just trying to give you a sense of how this unfolded for any Canadians listening. I hope this didn't reproduce the anxiety of living through those rather unexpected couple of months, 14 weeks. But let me take a closer look at the response in a more thematic way. So on the first slide, let me just emphasize, in Canada, this has been what I'll call a total government response. So not just a whole of government response where every department, every agency of the Canadian government is engaged, but it's more than that in the sense that the entire force of the government is being brought to bear to address this serious threat. And I think that's different than what I think we've seen in some countries, or at least the total government response in Canada came quite a bit early, around the time when we had 100 cases of COVID-19 in the country, which is much earlier than other countries, partially because we benefited from knowledge of how this unfolded in other countries. So part of that total government response was an $82 billion economic aid package. There's that $72 billion wage subsidy program I just mentioned. As well, one of the early things was announcing a $250 million Canadian dollars to enhance capacity in research and development, as well as in the manufacturing of countermeasures. So this happened pretty early in the outbreak, and is quite fortunate given the way that global supply chains are right now with the manufacture of medical countermeasures, but also noting how important the research response is to an effort. And on that note, in terms of the research response, I bring this forward because I'm quite proud of it, because this is partially something I've been involved with. And so I think the important thing to note is that it was January 20th, actually, that the Canadian Institutes of Health Research activated its own emergency response. And that happened before Canada had a single case of COVID-19. And indeed it was, so on January 20th, I remember I was flying, I remember boarding a flight in Europe on my way home. And I remember boarding the flight, getting the news that Chinese President Xi made a public statement asking Chinese authorities to make sure that all data and everything was being released and public to the world. And I remember thinking that was quite an extraordinary statement from the presidents of China. And when I boarded that flight, I was thinking, is this going to be that next that inevitable pandemic that many of us had been thinking about and preparing for? And when I landed on January 20th in Toronto, where I live, it was clear that new numbers had come out of Wuhan, China, and it was clear that this was going to be a thing. So it was that night that I called my counterpart, who leads the Usher Institute of Infection and Immunity, and together we activated that response right away at that point, before it had even reached Canada. That was 10 days before WHO declared a public health emergency. And then within a few days after that, we had already pre-announced that we were going to be doing a funding opportunity. And then a few days formally launching it. As you'll see in the timeline there, we gave researchers 1 week to apply. The reason wasn't Of course, 1 week, well, we never give enough time to researchers to apply for funding opportunities, but certainly 1 week is not the ideal time, but we knew that we needed to act fast, and we did. Giving researchers 1 week, we then gave ourselves just over 1 week to facilitate the peer review process, which was an amazing act of generosity from the peer reviewers who volunteered and reviewed at paces we've never asked them to do before. And then February 28th, those who applied knew that they were funded. And then the good news is, because this process went so well, it was 3 weeks later that Cabinet approved additional funds in order for us to support essentially double the number of projects we were able to fund based on that earlier call and those submissions, together being $54 million. That's just through CHR. There's been other research supports through other agencies, including our National Research Council, as well as, of course, all of this was a partnership across the federal government's research agencies, including the Natural Sciences and Engineering Research Council, as well as the Social Sciences Humanities Research Council, Canada Foundation for Innovation, Genome Canada, and certain provincial health research funding agencies. Moving beyond research, though, wanted to emphasize that we've seen unprecedented policy action in Canada. If we just look at the federal government, what they've done, they're really responsible for what happens at the border. So first it was border screenings that happened again before Canada had its first case. Then it was border closures, first to most of the world, and then secondarily to the US. And that's because of the close internet connection that Canada has with the US. In terms of global integrated supply chains, as well as the fact that there are many Canadians who live on, and Americans who live on one side of the border and work on another. The third was around mandatory quarantine, which we saw for people coming back to Canada, now having to be in quarantine for 14 days. Then within Canada, this is more within the realm of the provinces and cities. We saw school closures. Then we saw requests for people to work remotely, as well as limits on gatherings. I remember there was 1 week where on the Monday, we were asked to not host gatherings of more than 250 people. Then I think it was on a Tuesday, it was 100 people. Then it was 50 people, Thursday, 10 people. And by Friday, it was no gatherings larger than 5 people. And today, actually, for those living in Toronto, like I do, our mayor has signed an order, earlier this week signed an order saying we're not, in public places, no Torontonian can be within 2 meters of each other in a public place, unless they live in the same household. So that's, I guess we can be more than 2 meters apart, but we can't be within 2 meters. That an extraordinary physical distancing measure like we've never seen before. There's been closure of non-essential businesses and closure of parks and recreational centers. The financial measures that have brought to bear are enormous, as I mentioned earlier. So there's that Canada Emergency Wage Subsidy, that's the $72 billion initiative. And that small bit of text there would be financially similar to everything else combined that's on the slide. The other thing the government has done is made available credits to businesses, as well as guaranteeing loans to better enable banks to take on risk during this time. Businesses are able to defer the payment of sales tax and duty payments, and the government's given all Canadians extra time to file their annual tax returns, which is great for all citizens who might need that extra time. Or if they don't. There's been a huge investment of resources to support Indigenous communities in Canada to mobilize an Indigenous-led response to COVID-19, as well as there's been support for individuals and families through loan payment moratoriums, mortgage deferrals, as well as unemployment assistance. The last sort of bit of strategies I'll focus on are communication strategies. This has been, I think, one of the most interesting and visible aspects of the Canadian response, which is from very early on, our Prime Minister decided to give daily press briefings. So it's every day, it's at the same time, it's at noon. Our Prime Minister makes a statement and then makes himself available to media for questions. And then that is immediately followed by a daily press briefing from our chief public health officer. So that's the top doctor in our country. There's frequent press briefings across provinces and municipalities. And there is a one-stop shop website on the Canadian government website. It's canada.ca/coronavirus, where basically everything is there, enabling Canadians and public health professionals and others around the world to see everything all in one place. And then in terms of messaging, I would say that there's a surprising consistency in the messaging that we've been seeing here in this outbreak. Not 100% consistent, but we wouldn't expect that, right? I mean, there's different, every province and every city has its own unique context. We would expect slightly different messaging, but it has been surprising at how consistent it is. That's very different than what we saw during SARS in 2003. And I think that that's probably the result of that public health architecture that I mentioned right at the beginning. There has also been an emphasis on a whole of government response. This is not just a public health response. This is a total government response. And what I think that has been quite refreshing is that the leaders in Canada have really been emphasizing and frankly acknowledging that we don't know everything, and that what we know tomorrow will hopefully be more than what we know today, and that the response will evolve in light of new evidence and in light of new circumstances. I think that kind of acknowledgement has been really important in highlighting that we actually don't know everything and priming Canadians to know that we might have a change and we might ask of them something different next week than this week. I think that's important. So the Spider-Man fans among us might recognize that statement that, so with great power comes great responsibility. I flipped it here. So I think what we're seeing in this pandemic in Canada and many other countries is that with the great responsibility that national governments and subnational governments feel on their shoulders comes great power, in the sense that they're asserting enormous power, as I said, total government response in order to address this outbreak. Several provinces in Canada, for example, have declared states of provincial emergency. Federally in Canada, there's the use of the Quarantine Act, which is an extraordinarily powerful act of Parliament, demanding all people coming to Canada to be in a 14-day quarantine period under threat of severe penalties. These are extraordinary powers that are being used in this extraordinary time. And I think a lot of it comes from this sense of great responsibility that governments have, that public health has. So what's next? I don't know. And I guess time will tell. Certainly, we're seeing this unfold on a day-to-day, and every day seems like we're seeing new things happening in our country and around the world. But in terms of what's next, I did want to focus on the fact that we're trying something quite different here in Canada and frankly around the world. I mean, we as a global community are trying to literally change the trajectory of a pandemic in a way that we've never done before, right? So in the past, pandemics happened and we tried to mitigate consequences. We're literally trying here around the world to change the course of this pandemic. And we're doing our best. We're using extraordinary means to do it. But I think everyone would agree, at least in the public health community, that the end game for this is hopefully not going to be the point where enough people get COVID-19 such that there's global herd immunity. We want to stop it way before then. But if we are to stop it before then, there's really only, in my view, only 4 scenarios, all of which depend on science. So one scenario is we can boost immunity through a vaccine, right? So boosting immunity, that'd be one great way out of this. A second is we can reduce the severity of COVID-19, such as by developing or trialing effective treatments, thereby reducing severity, reducing case fatality to a point where we can go back to business as usual. A third would be about scaling containment. So this would really require a kind of huge scale up and of a rapid diagnostic testing capacity. We're not yet there in Canada, but certainly we're looking and watching some other countries that have rapidly scaled up testing and have done it in really innovative ways, trying to see what we can learn from those contexts. And the fourth would be about trying to have our measures that we're currently doing, like physical distancing, in a more targeted way, specifically based on whether people have immunity or not. And that would depend on mass serological immunity testing and the development of that approach. So I did want to just reflect on two more things. One is that I think that we are clearly in an extraordinary time, and I think that we can think of these times as, of course, requiring a robust response like we've never seen before. But I think emergencies are also some of the best opportunities to reflect on what really matters to us. We need to get through this outbreak, making sure that we can recognize ourselves at the end of it. And so I hope that governments and societies around the world are really taking stock of what matters most to them and protecting those things as cherished things that we don't, where there's lines that we don't cross. So for example, in the Canadian context, I think thus far, there's been a very good approach to ensuring that we are thinking of human rights. We are protecting democracy, multiculturalism, and diversity. That might become increasingly challenging as this outbreak proceeds. But I hope that our core values, we actually don't compromise and indeed are able to embrace as informing the response, the kind of response that all Canadians and maybe the whole world would be proud of at the end of this. And I hope every country does the same during this time. We do need to recognize ourselves when we get through this. The other thing is that I'll end on is just reflecting on the fact that I hope we learn from this outbreak. I think there's been too many public health scenarios, what we've seen in the past, where we haven't learned, or if we've learned for 3 years and then we forget. As someone who studies pandemics myself in my own research, it's hard outside of a pandemic context, it's hard to get governments, research institutions, civil society interested in preparing for pandemics when it's this far off thing that might or might not happen. We knew that a pandemic was inevitable. It was only a matter of time. And indeed, COVID-19 is actually not the worst case scenario that we've been thinking about and planning for. So the key in my mind is we need to learn to do better in the future. And we need to learn not only to make sure that we are prepared for the pandemic that comes after COVID-19, but also to use this as a learning opportunity to see how the world reacts to pandemics like COVID-19. So for example, one of the key learnings that I've had is that I think we were maybe preparing for an outbreak of a virus, but we weren't preparing for the outbreak that comes with that outbreak of the virus, which is an outbreak of fear and misinformation, stigma, and quite a bit of racism that we've seen in this outbreak. And I don't think we were ready for that. And it's now that we're having to equally respond to that outbreak of fear as the outbreak of virus, something to work on for the future. So with that, I'll conclude and very much looking forward to questions with everyone. Thank you very much.
Thank you very much, Stephen. That was excellent. And I think covered a lot of things that people were very interested in and hoping to hear from you about. So we've had a range of questions. I've also been emailed several questions. So we'll try and get through those. You were perfectly timed. We've got 20 minutes, so we should be able to get through all the issues. Colleagues, if you've got additional points that you're pondering, please do put them in the Q&A box. So I'm going to start by just taking the liberty to ask Professor John Frank, who, as you know, Stephen, was the founding director of the section of CIHR that you are now leading. And he sent me a question in advance, which I think you partially answered on slide 4, but maybe you can add a bit more detail. So Canada had the benefits, unfortunately, of learning from SARS, as you've already said. But at the time, there was a notable lack of federal, provincial, municipal coordination in the public sector. So to prevent that recurring, as we know, the Public Health Agency of Canada was established. in 2004. So if you can just tell us a little bit more about the extent to which its presence has created a more organized and collaborative decision-making response particularly across Canada's 3 levels of government, which of course, in contrast to the UK, there's a lot of autonomy and action that takes place at the provincial level and also at the municipal level, probably more than we have here.
Great. Yeah. First, just to flag, it's always great to hear from Professor John Frank. So indeed, John, I've been thinking about John recently because he was the one who led the Government of Canada's research response to SARS, and at that point mobilized the research community at a pace that had never been done before. And when we were launching our rapid research response to COVID-19, we used that response as our benchmark, trying to be, could we be even faster than John was back in 2003? So great to hear from you, John. In terms of the question, I think that the creation of the Public Health Agency of Canada was a game changer for the Canadian response. So the kind of lack of coordination, miscoordination, embarrassing situations that were present in Canada during SARS, we have not seen at all in this current outbreak. Our response is not perfect, but no country's response is going to be perfect during a pandemic. But the fact that we have a very clear authority and that we have a very clear chief public health officer who's widely respected and who has been not only asserting leadership during this pandemic, but indeed has been working with her colleagues in a collaborative way ever since she was appointed and ever since these structures were created after SARS. What that means is that those networks are in place such that they work well together. They've been surprisingly consistent, and they do have a mechanism to come to the same page on different things. It's not going to be exactly the same page, but it's been remarkably consistent and I think quite effective. So it's a totally different picture than what we saw in SARS, which as much as I'd like to say, I mean, SARS was obviously a terrible situation for Canada, but I think we were able to learn some harsh lessons and benefit today because of that.
Thank you. So the next couple of questions are on contact tracing and testing, which is a big issue for debate and discussion here in the UK. So first on contact tracing, when you had few cases, did you have that in place and how did you implement it?
Yes, so that was actually, I think, part of the both luck and success of what happened in Canada. Our initial cases were all quickly identified and very quickly contained so that they didn't spread. There was some of the early cases, it was a husband spread to a wife, that kind of scenario within a household, but it stopped there. That was partially, I mean, eventually, of course, we now have over 18,000 cases in the country. But what that meant was those initial cases, because they were contained through contact tracing, we were actually able to delay when the real frontier of the outbreak hit Canada. And by that point, we were able to look to what happened in other countries and informed our response. So yes, we definitely did contact tracing. And that happened as long as there were a small number of cases. It actually happened quite deep into the outbreak response. And indeed is still some, not one, it's now there's still sort of alerts that can go out, but not in the same way, given the number of cases.
Okay, and you don't need to answer this, but presumably it's something you'll re-implement more rigorously when you get fewer cases, which again, we're discussing. So could you just tell us a little bit more about the testing regime and the strengths and weaknesses of that?
Yeah, so Canada had the ability to test for COVID-19 actually the day after Chinese authorities posted the genetic sequence of this virus online. So we have a national microbiology lab, which has very sophisticated facilities. That's based in Winnipeg, Manitoba. And that lab was then able to lead and support labs across the country, provincial authorities, to do this testing. So even now, the provincial labs that now have the capacity to do this, they're able to double check and use the National Microbiology Lab as a reference point. So that testing was available in Canada right away before we had cases. And they're also, particularly in a province like Ontario, which I know best, there is capacity to do thousands of tests per day. Now, in the context of this outbreak, thousands of tests per day is actually not enough. But up until now, it has been sufficient. Where it's been more challenging is the certain materials needed. Like we had a shortage at one point of the nasal swabs in order to get samples. That's been fixed. And then there was a shortage of reagents. That's been fixed. But actually from a lab capacity perspective, in Ontario, my province, it's about 10,000 tests per day that can be done. And that's in a province of 8 million people. Not enough for this outbreak, but much better situation than many countries have found themselves in.
Yeah, the fact that you had a central lab that then spread it across to the provinces and was able to very quickly spread other labs, something that did not happen here until too late. Okay, so I'm trying to go and combine two questions now, which are about healthcare workers. So there's been a lot of concern here about the provision of PPE, personal protective equipment, in terms of the systems to deliver that and make it available to everybody. And then the second one, and I don't know whether you can answer this, and you might not be able to, is we've seen in our press today that mortality is 60% higher in Scotland over the last week of reporting than it has been at all in the immediate past. And that's not people dying from COVID, it's people dying from other conditions. So what were the decisions about suspending elective care, for example, or other non-emergency treatments?
Yeah, so in terms of personal protective equipment, this is an ongoing challenge. Thus far in Canada, we haven't had shortages of the kind that are certainly filling our news media from what we hear from the United States. Partially that's because we had stockpiles of this equipment, but even more so it's because in Canada, we've been able to move the personal protective equipment around between hospitals. Our hospitals do run as independent authorities, but because we have a single payer system, it's government that's paying for all medically necessary care. What that means is there has been able to be coordination of the kind and moving. If one hospital is running out, they just get it from another hospital. And that's worked quite well up until now. But that is an ongoing issue in terms of a future supply. And governments have been taking steps to try to generate internal capacity, like switching manufacturing capacity in Canada from other things to personal protective equipment and other medical needs. In terms of the other question, I think it's really important. We in Canada have been systematically deferring elective surgery, canceling appointments, and I certainly am worried about what that means for people. So, I mean, anyone who is on the waiting list to have cancer treatment is obviously going to be feeling extremely anxious when their treatment gets postponed. I mean, people in every country in the world are going to die and be affected because of well, in addition to COVID-19, it's all the things we can't do in light of COVID-19 in the health system. But also, frankly, I'm also worried about all the downstream consequences of things like poverty. Or, I mean, we have 3 million Canadians who've lost their jobs over the last month. That's a lot of people who might suddenly not be able to buy food, or whose lives became much more precarious. In addition to the immediate needs and the mental health consequences that go with it, there's full-on social dimensions to that as well. That's certainly something that our institute, the Canadian Institutes of Health Research, is looking at, those downstream consequences. Because one thing that we saw in the Ebola outbreak in West Africa is that when all was said and done, more people died in West Africa during the Ebola outbreak from being unable to access regular health services that would usually be available, but were not available because of Ebola, than who died from Ebola itself. So that's highlighting we can all learn from each other, and that's something hopefully we'll be able to learn in Canada.
Yeah, and I'm sure some of the research that you've commissioned will help shed light on that as well. Another completely different question, there's a data on the characteristics of people who develop COVID and are treated, particularly, for example, in ICU, etc. It's expanding weekly, daily across the world. And one of the things we're seeing is striking ethnic differences. And I don't know whether you know in the data from Canada whether that's the case as well, or maybe there are not enough cases to be able to observe that.
I'm not sure. I do know that it is being looked at by our public health officials. The other thing that's actually from the very beginning we've been looking at is differences according to sex and gender. So that's been we in Canada in our health portfolio have a SGBA plus framework that basically requires every policy and program that we do as part of the health ministry's activities have to consider sex and gender in their design and implementation. So that's been at the fore. But of course, Canada being one of the world's most multicultural societies and racially diverse societies, that's high on our radar. I don't know the data myself, though. Apologies.
Okay, and then another question is, so the travel restrictions that were imposed were at the national level. Did you try and restrict travel within Canada at all? Is that on the cards, or tell us a bit more about that?
Yeah, so that's been a place where there's maybe been a bit less coordination in Canada. So it's a great question. There have been a couple of provinces that have implemented some attempts to implement some restrictions. So for example, there was a time that Quebec had closed certain bridges between Quebec and Ontario in order to reduce traffic and to concentrate traffic where officials would be able to speak with people going into the province. I mean, we have a very open country, so it's not really possible to do it systematically, but there was that attempt to try to reduce or redirect traffic in a way that would be maybe helpful. The one province that can more easily do it is Prince Edward Island. It's our smallest province. It's an island, as it's the name of the province suggests. And so they were able to not stop travel, but they imposed certain restrictions asking people to self-quarantine if they come onto the island. And as of today, or as of yesterday, that province has 22 cases, so it still has reached the island.
Yes, we're seeing great success, I think, in New Zealand as well, in terms of these places that can contain their efforts. So just tell us a little bit more briefly, I know you can't do this in detail, about the type of research that's been funded and when we'll see the findings from that.
Yeah, so in Canada, our focus in that initial call was very much focused on countermeasures, in the sense that it was really about, it was in a containment mode as opposed to what I call a mitigation mode. So it was really about, okay, how do we stop this thing if it gets worse? Because remember, we launched that before Canada had a case, and we launched it before it was declared a public health emergency of international concern, before it was a pandemic. So we were still in containment mode. We divided our response into two different parts of containment. The first was on medical countermeasures. So about half of the projects funded were focused on things like therapeutics, including trials for what kind of existing therapeutics might be effective against COVID-19. Others were about the basic science of how does COVID-19 transmit. Still others were on vaccines, or one project was focused on masks. Then the other half of the projects were focused on social and policy countermeasures. And I think this was very much out of recognition that at this point, our response is actually more so a social response, right? Because we don't have effective medical countermeasures yet. We have personal protective equipment, that we have, but we don't have a vaccine, we don't have a therapeutic. So we need to make sure there's more research on the social and policy side. And just as an aside related to that, I find that very often research funders don't take as seriously the social and policy response. I mean, we as global society massively underinvest in social science research and in policy research, and that's to our own peril. So I'm really pleased that in the Canadian context, we were able to sort of recognize each as being an equal contributor and funded accordingly. There's been other efforts in Canada, and by all accounts, I mean, this outbreak is not over, and so the government's response, including its research response, is not over. And I would expect, though, that if there was further efforts, we are increasingly seeing that need to focus on the mitigation as well, adding that to the research response.
A couple more questions. We're doing well. Domestic violence. So you've seen the reports from France and other places, and even here in the UK, we've seen the rates, so the reporting of that increasing. Just tell us a little bit about whether that's been an issue in Canada.
Yeah, so I'm very glad the question was raised. This is one of my biggest concerns, and I mean, we know that, so it's a couple of things. We know that when there's school closures, there is research that shows that can lead to higher levels of domestic violence. We knew that, that's based on previous outbreaks, we knew that. And then we also knew that when families are forced, contained, and like what we're seeing now in this extreme, that there also has that risk. And then when we've been seeing data coming out of Italy, India, the statistics were very stark out of India. That became a top of mind concern. We don't have the data yet in Canada, but our hope is that it's not similar to what we've seen in other countries. It's very top of mind. We've been actually talking about it quite a lot at the Canadian Institutes of Health Research and with our colleagues at the Public Health Agency of Canada.
And then the next question is about First Nations. So you already mentioned that you had a specific package of support for them. But are there any provisions for remote reserves, for example? And how many cases have you seen amongst First Nation communities?
Yeah, so in Canada, we have 800 different Indigenous nations. And one thing that happened more recently, several years ago now, was establishing or an attempt to establish nation-to-nation relations with Indigenous communities, recognizing the need to move towards and support the self-determination of Indigenous peoples, and allowing and enabling Indigenous peoples to drive their own response to the challenges that they would prioritize. And so that's the way that this is structured in Canada, is that it's not the federal government sort of parachuting in and providing what's needed. It's really about working with, or the attempt is to work with Indigenous communities to lead their own response. So what that means is you have 800 different nations, there's going to be 800 different responses, but significant financial resources have been mobilized. And indeed, I have heard of reports of some Indigenous communities deciding to close their community to those who are not members of that community. And that's more viable when it comes to remote Indigenous communities, but actually over half of Indigenous peoples in Canada live in cities. And so of course, that's not as possible there. But it's maybe what I'll just say that the short version is that there's 800 different nations, 800 different responses.
Okay, last question, actually two parts, if we can just be brief. So public compliance with restrictions is key. You've talked about the daily briefings, that's great. Are there other things that are being done to secure public buy-in? That's the first part. And then the second part for me is, when do you think the Canadian government is going to start talking about exit strategies, loosening the lockdown and that kind of thing?
Yeah, I'll take the second one first. So in terms of exit strategy, we heard for the first time yesterday our Prime Minister remark on that. What he indicated yesterday was that there is the expectation that the robust physical distancing measures will be in place, likely for a few months, and that after that, there is hope that they will gradually be released. So that was the first time we heard about a gradual response, which isn't surprising. I mean, that's what we'd expect based on from a good public health rationale. But we heard it yesterday from our Prime Minister on that front. And then in terms of the public trust, I think it's really been about messaging and communication and being open. I mean, we have some amazing chief public health officers across our country right now. I mean, these are heroes who have been coming out, and the public response to some of them has been like treating them like rock stars. I mean, people are now making T-shirts with their faces on them. People have posted YouTube videos and written songs. I mean, in particular, we're talking about Dr. Theresa Tam, who's the National Chief Public Health Officer, Dr. Bonnie Henry, who's the British Columbia's Provincial Health Officer, Eileen de Villa, City of Toronto's. I mean, these are people who have become maybe the new celebrities in the time of COVID-19. But I think it's because of how clear and how honest they've been to Canadians. And I think that's really important.
Fantastic. Well, I think for everybody in public health is a very busy time, but it also gives us an opportunity to, and for the public to see a little bit more about what public health in practice actually means. So that was absolutely brilliant, Stephen. Thank you very much indeed. Just to emphasize, colleagues, that Stephen very kindly shared his email in the last slide there. I didn't get through all the questions, although we dealt with most of them. Stephen's happy to address any further questions by email, so please do send him a message. We'll also be sharing the slides. Do let your colleagues know that it was live streamed on YouTube and they can watch again. That's been very popular in previous weeks. I'm just going to highlight the next two speakers and say something about others. So our next speaker, as you know, next week, Friday the 17th, which I'll be chairing again at 10 a.m. from Hong Kong, Professor Ben Cowling. And then the following week, the Friday the 24th of April at 9 a.m. From Professor Jerome King, who's been doing a lot of important work on vaccines. So please do highlight that to your colleagues. And also, we know South Korea has been another example of a country that's had some success. So great to hear from them. We're securing a speaker from Africa and also in contact with colleagues in a number of other countries, including Italy, to try and sequence those presentations. In future, we'll be looking at trials that are happening and more research that's underway as we go into May and June, so we can keep the information flowing. But thank you very much to all of you for listening, and sincere thanks again to Stephen for being such an excellent speaker. Thank you.
Thanks for having me.